Everyone. First of all, I would like to welcome all the attendees and to welcome Sarp and thank him in the name of all the organization of the seminars for joining us and to accept the invitation to present the seminar today. So Sarp was born in Turkey and graduated in the Faculty of Medicine in Ankara as well. But very early into 2016, he enrolled the Ph.D. program in the tumor biology PhD program in 2026 in the same university. And later on, in 2021, he started his journey in the University Hospital in Basel, where he's still working today. His work is mostly focused on molecular and morphological analysis of immune-mediated liver diseases, primarily in SARS-CoV vaccine-induced liver injury and the checkpoint inhibitor-induced liver injury. And I'm sure that this will be the theme of your talk today. So please go ahead. Thank you.
Thank you very much for this kind introduction. Also, the invitation. It's a great pleasure to present my data here in the seminar series. As you said, today I'll be talking about a new entity, liver injury after SARS-CoV-2 vaccination, and its molecular and morphological characterization analysis. So I would like to first start with a brief introduction. So first, case of vaccine-induced liver injury. So in the rest of my presentation, I will call it as a VILI because it's easier to pronounce like this. So the first case of VILI was first described in 2021 after the start of mass vaccination program. And following this first case report, many other case reports has been published and supported this first finding published in 21. And then a very interesting paper came out in 2022 from Freiburg, and they actually identified a spike antigen-specific T-cell clones in the liver tissue of a VILI patient, and they further characterized these T-cells as CD8 positive T-cells, and they also show that this is a CD8 T-cell dominant hepatitis. And in a following study, it was also shown that vaccine mRNA can find in the cytoplasm of hepatocytes in a VILI patient. And following those basic research studies, larger cohorts were published, and the first and the biggest cohort in the literature published in 2022 in hepatology, and here 87 patients were characterized clinically. And following this study in 2023, histological and serological features of the VILI disease were further investigated, and it was shown that actually 70 to 80% of the patients with VILI show histomorphologically autoimmune hepatitis like morphology, and serologically most of those patients were seropositive. So in these early studies, it was shown that this disease really morphologically looks quite similar to autoimmune hepatitis, and it was shown in other case reports, many other case reports, and these large cohort studies, and therefore we decided to perform a comparative analysis between vaccine-induced liver injury cases and autoimmune hepatitis to further analyze this disease. And in this talk, I will be mentioning about our recent study, which was published in Journal of Hepatology in 2023. And also a very interesting paper came out a couple of weeks ago from United States. And in this study, they collected a Willi cohort, and in their cohort, they found a significant association between Willi patients and ARAP1 and ARAP2 gene variants. And these genes are actually involved in the process of peptide processing and MHC1 pathway, and this might explain actually the potential predilection of some patient to this rare disease. I divided today's talks into two. First, I would like to show you our data from our study published in 2023. And I'll show you some data, important data from this study. And then I would like to show you some unpublished data that we worked on recently. And we use a case that was already published as a case report. And this very same patient was also, sample of this very same patient was used in other studies, these large studies that I already mentioned before in the previous slide. First, I would like to focus on our published study. So first, we collected a cohort of Willi patients, and we managed to obtain 6 formalin-fixed paraffin-embedded liver biopsy samples and performed our analysis with these samples. And as you can see here, the age ranges from 21 to 85, and all patients received Moderna vaccine because it was the vaccine of choice in Switzerland. And so 2 of those patients, actually among 6 patients, already published as separate case reports. And the time onset to the symptoms change between 2 days to 28 days, either after first vaccination or after second vaccination. And all patients show symptoms like fatigue or abdominal pain, and all patients had elevated liver enzymes. And except one patient, the other patients received steroid treatment, and all patients actually went to remission during the follow-up period. And of course, as a further criteria, we checked for other potential causes for liver injury and discarded the cases that were suspected of another potential diagnosis. And for the comparison, we also included autoimmune hepatitis FFPE formalin-fixed paraffin embedded liver biopsy samples from type 1 autoimmune hepatitis patients who were untreated at that time and initial diagnosis at the time of liver biopsy. We didn't want to include chronic cases to make a better comparative study. So as I said, we collected 6 liver biopsy samples and 9 liver biopsy samples from autoimmune hepatitis. And first thing that I did, I isolated RNA from those samples when we performed whole transcriptome sequencing and TCR and B-cell receptor sequencing. I will give some more details. And remaining liver biopsy samples we use for spatial transcriptome sequencing experiment and multiplex immunofluorescence staining experiment. First, I would like to show you some data from our whole and spatial transcriptome sequencing experiments. First of all, we isolated these RNAs and we performed whole transcriptome analysis from those samples. We obtained whole transcriptome data from these vaccine and autoimmune hepatitis samples, plus we included further controls such as HCV hepatitis and alcoholic steatohepatitis, and also 3 normal liver biopsy samples. So we performed a dimension reduction method to visualize all those information coming from whole transcriptome into this 2D plot. And for this purpose, we use principal component analysis. And as you see in this plot, vaccine-induced liver injury cases and autoimmune hepatitis cases were clustered closer to each other, but the other cohorts were separated. This means that actually vaccine-induced liver injury, autoimmune hepatitis cohorts have a similar transcriptome profile, but some patients, as you see here, were clustered closer to normal liver samples. And when we further investigated this finding, we saw that in our multiplex immunofluorescence staining experiments, actually those cases had lower inflammation compared to the cases that we had. And to further actually show that those are clustered closer to each other by using some numeric measurements, we use this heat map. And this heat map, actually what you see is that the mean differences between samples from different cohorts. So this yellow color indicates that cohorts are similar to each other in their transcriptome profile, and this dark blue color means that they are far from each other. So as you see here, autoimmune hepatitis and vaccine-induced liver injury cases have this yellowish color, which means that their transcriptome profile is similar, and which supports the 2D PCA plot that I just showed. And alcoholic steatohepatitis and HCV hepatitis cases were closer to each other, and apart from our AIH and VILI cases, and the normal liver was clustered separately. So this data indicate that actually those cohorts have a similar transcriptome profile. However, we further performed further analysis like differential gene expression analysis or gene set enrichment analysis by using the same whole transcriptome data. And what we observed is that actually in vaccine-induced liver injury, metabolic or mitochondria-related gene sets, pathways, were overrepresented. However, in autoimmune hepatitis, more immune or inflammatory pathways were overrepresented. So this finding we found important because it is known that in drug-induced liver injury, hepatocyte damage can arise from mitochondrial or metabolic alterations. So we hypothesized that actually this data comes from the damage of the hepatocytes, and also it is known that also we saw in our cohort that the damage type morphologically mainly hepatocytic type instead of cholangiocytic type. So we thought that actually these metabolic alterations might be important and might be a similar feature to drug-induced liver injury. However, the main challenge of the bulk RNA sequencing is that you collect the whole transcriptome data from all those cells inside your tissue. In this case, from hepatocytes, cholangiocytes, or immune infiltrate. And you cannot really know that from which this signal comes from which cells actually. And to further show that actually hepatocytes, the hepatocytic damage or this metabolic alteration comes from this hepatocytic compartment, we thought that we can perform a spatial transcriptome experiment, and it was a part of a revision in our paper. So we already, before doing this experiment, we already created a liver biopsy tissue microarray for the immunofluorescence study, immunofluorescence staining study, and we used the same tissue microarrays for spatial transcriptome experiment. But I just want to describe you how we did it. So basically, we had this liver biopsy FFPE samples, and we first melt the paraffin and took a 5 millimeter tissue sample, and we aligned them as you see here like this. So each piece belongs to a different patient, and then we re-embedded in a paraffin block. And so here you see the hematoxylin staining. We also include some tonsils for positive control for immune cell staining, and a normal liver biopsy for negative control. And the remaining samples are either from vaccine-induced liver injury cases or autoimmune hepatitis cases. And then we perform spatial transcriptomic experiment by using a technique called GeoMX Deep Spatial Profiler. And basically in this technique, you apply a whole transcriptome panel on your tissues, a probe set, and those goes and binds to your RNA. And plus, you can also stain your tissues with some chosen antibodies for immune fluorescence staining. So in this case, we chose arginase to mark the hepatocytes, CD3 for the T cells, and CD20 for the B cells. And then we also perform this staining. And by using this staining, you can choose some certain regions in your, in this case, liver sample, and you can segment these regions and collect the whole transcriptome separately from these regions. So as an example, so here you see an autoimmune hepatitis sample. Here we collected data from these regions that is marked with a circle, and specifically from the arginase positive cells, either from central region or portal region, which were mainly inflamed in autoimmune hepatitis or in our vaccine-induced liver injury cases. So we collected these data from each sample and from autoimmune hepatitis and vaccine-induced liver injury, and we performed the same comparative analysis as we did in the bulk RNA sequencing, whole transcriptome sequencing that I showed before. And we saw 53 differentially expressed genes in our cutoff values, and some of those genes were actually related with the oxidative phosphorylation pathway or the metabolic pathway. And we further actually saw this in our gene set enrichment analysis, and in the vaccine-induced liver cases compared to autoimmune hepatitis cases, we found similar pathways that were overrepresented or enriched compared to the autoimmune hepatitis. So this means that actually data that we observed in whole transcriptome sequencing actually comes mainly from the hepatocytes, especially for this metabolic pathway alteration part. And so this finding, we found it important because this actually supports that vaccine-induced liver injury shows some similar features to drug-induced liver injury. So this was the first finding, and we wanted to further characterize the immune microenvironment of this disease. And for this purpose, we use a multiplex immunofluorescence staining technique. And then first, I would like to describe this technique a little bit. So this is formerly called as Codex. Now it's known as PhenoCycler. The name has been recently changed. And basically, you stain your samples with a antibody panel. And these antibodies are special because these are conjugated with unique oligonucleotide sequences, as you see here. And those are like barcodes because each antibody is barcoded or conjugated to a specific oligonucleotide. And then by using another set of oligonucleotide, which is conjugated to a fluorophore, you can actually match these sequences. So those sequences from these unique oligonucleotides match with certain fluorophore conjugated oligonucleotides. And so in an iterative way, in each time you apply 3 different oligonucleotide conjugated fluorophores on your tissue. As you see, it's just 3. And then, of course, these fluorophores emit a signal in different spectrum. And then you collect a staining data. This is called as one cycle. And then you wash away those oligonucleotide conjugated fluorophores, and you apply another set of 3 oligonucleotide, which is conjugated to a fluorophore. So by doing this, each cycle, you can obtain data from 3 different antibodies. So in the first cycle, 3 antibodies. In the second cycle, 3 different antibodies, and you can go up to 10, 20 cycles. This means that you can go up to 30, 60 antibodies, and even the company showed that you can go up to 100 antibody staining. And we performed this staining on our liver biopsy TMAs that I showed before. And we had 3 different liver biopsy TMAs. We acquired the image. I used just a small panel of antibody of around 15 antibodies. And after acquiring the image, we performed a pre-processing by using a pipeline developed in our microscopy facility. We performed a background correction, illumination correction, and tile stitching. And at the end, we obtained a image. And this image, of course, contains signal coming from different cells. Also, the nuclear staining, which you can see with the DAPI. And by using this nuclear stain, we were able to segment each cell, and we were able to analyze those cells in a single cell level. So these red hollow you see is the segmentation. So we collected data from more than 240,000 cells. And then, of course, we collected data, proteomic data coming from those cells, and we used a unsupervised clustering algorithm called phenograph to cluster those cells into separate groups according to their protein expression. And so I used certain sets of markers that I included in my panel. And after obtaining clusters, we validated those clusters on the tissue, and we merged some clusters or discarded some clusters if we see a false negative staining, false positive staining. And at the end, we annotated our clusters of cells like CD8 positive T cells, CD4 positive cells, and it goes like this. And on top, what I did was I annotated portal vein and central vein by using CD31 staining. And I expanded this region and collected the number of cells, cell abundances of those cells that I mentioned around the central and the portal vein, because the main inflammation we see around portal and central regions. This is why I performed the analysis like this. And I would like to show you some results. So this cyan staining, cyan color shows the CD31 positivity. So these are portal vein on central veins, and these regions were validated on hematoxin and eosin staining. And so as I said, I actually calculated the number of cells around these regions. So here you see some results. So for example, for CD8 positive T cell density, I calculated the number of cells around this region and divided to millimeter square. So you see is the number of cells per millimeter square. So, and as you see here, in both portal region and both central region, we observed a higher median CD8 positive T cells in Willi cases compared to autoimmune hepatitis cases. By contrast, we mainly observed CD79A positive cells in autoimmune hepatitis cases, both in portal region or also in the central lobular region. CD79A, I chose this marker as a pan-B cell marker because it can detect the CD20 positive naive mature T cells, plus you can also observe CD138 plasma cells. So it's like a pan-B cell marker. And this CD8 dominancy was already shown in the single case of the Freiburg group, and this data also supported this finding. And autoimmune hepatitis is also a disease which is also very well known, that the involvement of the B cells on the plasma cells is very well known. So as a summary, we observed a CD8 T cell infiltration in the vaccine-induced liver injury. So then we wanted to focus on the T cell and B cell repertoire architecture in the tissue. So this means that we would like to see the specific T cell clones or B cell clones on our samples. For this purpose, we use a technique called T cell receptor sequencing. Then I would like to explain you how we actually use this technique. Today, I will just show you the T cell part because as I showed you before, the CD8 T cell involvement was very prominent, and I think that the CD8 T cell involvement is the major component of the disease. So this is why I would like to focus more on the T cell part. And briefly, I would like to show you the T cell receptor structure. So each T cell is composed of an alpha chain and beta chain, and each alpha chain and beta chain is encoded by different gene segments, namely variable, diversity, D genes, or J genes, joining genes, and their rearrangement actually makes the TCR beta or the alpha chains. And very importantly, the most diverse region of this TCR beta chain is the CDR3 region because it gets the gene segments from both variable and the joining genes, and it is the most diverse region. And this diversity actually gives you the response to different type of antigens. And for this reason, if you're able to sequence the CDR3 region, and if you combine this information with variable and joining gene information, you can obtain T cell information coming from different T cell clones. So each T cell clone is defined with their CDR3 sequence, variable gene, and their joining gene. And for this purpose, we use a commercially available primer panel for next generation sequencing library preparation. I use the RNA, the very same RNA that I use for the whole transcriptome sequencing from vaccine-induced liver injury and autoimmune hepatitis patients. And I use this commercially available panel. This panel actually is really helpful to sequence the RNA, FFPE RNA sequences, because formalin-fixed samples have always really low quality RNA, and it's really hard to sequence those samples or amplify larger regions. But in this funnel, we have 80 base pair region, which is convenient to prepare next generation sequencing libraries. This is why we use this panel quite often with RNA samples. And we sequence those samples, and at the end, we obtain valid and next generation sequencing data from 6 patients from VILI and 6 patients from autoimmune hepatitis. And I discarded 3 patients of autoimmune hepatitis because the data quality was low, most probably due to RNA degradation. It did not perform very well with my panel. So before showing the results, I just would like to introduce a concept called diversity. So here you see different circles with different colors. So here each actually circle represents a single T cell clone. And these orange clones or green clones are actually the same clones. So here you see a homogeneous population of T cells, different number of clones from each color. And so this homogeneous population means that actually the diversity is higher in this certain T cell population. And this we can measure with a metric called Shannon Diversity Index. Also, you can measure this with another metric called evenness, which is also known as normalized Shannon diversity. This normalized means that you normalize this Shannon diversity data according to the number of T cells that you detected in your sample. Because as you can guess, if you increase the number of T cells, of course, the diversity might increase, and it can create a bias. Because of this, you prefer normalizing it. This is why I use this evenness value data more than Shannon diversity. This will be important for the data part that I'll show in a minute. And the clonality means the opposite of evenness or the diversity. So it is also calculated as 1 minus evenness. This means that if you have higher evenness, higher diversity, you will get a lower clonality. For example, here has a lower clonality, which means that is more polyclonal instead of monoclonal or oligoclonal. However, here you see a dominancy of this orange clones. This means that the diversity is low in the environment, so the Shannon diversity and evenness will be low. However, the clonality will be high, so this is what we call oligoclonal or monoclonal response. So when we look at our data, so I detected more T cells in the VILI cases, although it did not reach statistical significance with the test that I used. And in the Shannon diversity, I did not see a significant difference. However, as I said before, we normalized this data for the T cell clone number because here, obviously, I have more T cell clones detected in the VILI cases. And then, as you can see here, evenness values, VILI patients have lower evenness than autoimmune hepatitis. This indicates that actually VILI has a more oligoclonal or not monoclonal, but it's more oligoclonal response. And autoimmune hepatitis, we have more polyclonal response. So the dominancy or the enlargement or higher frequency clones, we might observe more with the VILI samples than autoimmune hepatitis samples. And the polyclonality of autoimmune hepatitis was already shown in some other studies from the literature. And so this also validates these older studies on autoimmune hepatitis. And to further support this, we have these two patients, VILI patient 2 and VILI patient 6. For example, in this plot, this is called as a spectrotyping plot. In the x-axis, you see different variable genes. And in the y-axis, you see CDR3 length, nucleotide length. And by using these parameters, you can actually resolve, you can add a resolution and you can see different clones in different spots. So here, for example, this dark color indicates that we have larger clones, high frequency clones. So in these two patients, for example, we have some high frequency clones, although just few, we have some. In autoimmune hepatitis, we actually we did not observe these expanded clones in autoimmune hepatitis cases. And so this also further validates our finding with evenness that I just showed you in the previous slide. So of course, this data was in line with the previously published data from the Freiburg group, because what they actually showed was that they found this spike peptide specific CD8 positive T cell clones in the liver and also in the blood of this single VILI case. And this single T cell clone, this T cell actually showed liver residency phenotype with these markers and also activation phenotype with CD38 positive staining and the granzyme B positivity. So to sum up, actually this data from our study and this study actually can indicate that there might be some antigens. This might be a vaccine-related peptide or an antigen that actually mimics this peptide protein, which can be recognized by prime T cell after the first vaccination, and these T cell clones can recognize those antigens again. And in some predisposed patients, maybe patients with, for example, this IRAP1, IRAP2 gene variants that I mentioned before, and in those predilected patients, they can cause hepatocytic type of damage. And actually, so in my second part of presentation, I would like to focus on a really severe case of vaccine-induced liver injury, because we thought that actually this case might be very interesting to analyze, especially the T cell immune structure, because if it's the severest case, maybe we can detect a really dominant clone that can cause this disease or might be related with disease. This is why I collected samples of this certain case, which is actually the severest case, as I said before in the literature. I collected a liver biopsy sample and liver explant formalin-fixed paraffin embedded sample from this patient, and I'll explain in my next slide. So maybe you don't know about this patient, so this is why I would like to briefly introduce this patient. So this patient is interesting because first he received a first dose of BioNTech. It's this time the BioNTech vaccine, and then he developed some mild symptoms which improved under steroid treatment. But after the second dose of the vaccination, as you can see here, liver enzymes went high up and patient became treatment refractory at certain point. And then they decided to perform a liver biopsy, which showed features of autoimmune hepatitis. And during this time course, patient did not improve under treatment, even with the plasma exchange, and patient went under liver transplantation. And after liver transplantation, as you can see, liver enzymes went down. So I collected a liver biopsy sample of this patient and also the liver explant of the same patient, which is 110 days after the second dose of BioNTech, and the liver biopsy is after 89 days. And we performed this with collaboration with Dr. Cumali Efe from Turkey. This letter was also published by Dr. Efe in 2022. And so we performed this TCR sequencing again by using liver biopsy and liver explant samples. And what you can see here in the spectral typing plot again is that these high frequency clones, which is shown with a darker color, and here you see we have a couple of high frequency clones in liver biopsy, and again in liver explant we had high frequency clones, and we actually observed a similar finding in our other vaccine-induced liver injury case that I just showed you before in previous slides. And very interestingly, one of those clones here and this clone in liver explant got very high amounts of reads. So this pink bar shows the number of reads that a certain clone actually obtained. So here 60,000, 70,000 reads, and here 300,000 reads, which makes up a great proportion of the reads that I obtained from this patient. And then what we further did was actually to look for shared clones. Shared clones here means that actually the clones that we detected in the biopsy samples plus in the explant samples. So we hypothesized that there might be some clones which might be high frequency dominant and stay in the tissue during this time period of 21 days. And indeed, we actually observed 59 shared clones. Here you see them with this orange color, and you see with this green color unique clones of biopsy, and the unique clones in explant was shown with this blue color. And we of course had some unique clones, but also shared clones between those samples. But more interestingly, these two clones, actually the highest frequency clone both in biopsy and the explant, as you see here, they were actually shared clones. So this means that there are some really high frequency clones that can stay in the tissue during the disease progression. And to further analyze these high frequency clones, I ranked the clones according to their frequency. And then I chose the top 25 from the biopsy and top 25 from the explant. And then again, I performed this shared T cell clone analysis, which means the same T cells. And here I detected 6 shared T cell clones among these 25. But more interestingly here, as you see, the first clone, this one is the CDR3 sequence and variable and the joining gene. And actually this makes up almost 15% of the all clones, which is a very high percentage. And I can say we work on many samples with tumor samples or with ICI hepatitis, for example. I've never seen such a high value in many sequences that I've ever done with the other studies. So it's a really huge number, and it is a really high frequency clone. And also in the second clone is 4-5% of frequency. This means that the top 2 clones actually occupies the 20% of all T cells infiltrating those tissues, which is really high. And interestingly, I also observe another high frequency shared clone here, which has a really similar sequence, also same variable and joining gene to the top clone, which might indicate that there might be some converged to this clone, and these clones are maybe specialized to recognize some antigens in the environment. This is why they got high frequency. And to further investigate if I can find some similar clones from the literature, I used a database called VDG database. So basically this database collects published results of TCR specificity assays. So in this database, you can see some clones plus the epitopes that those clones can recognize. And also if it's a single cell data set, so you can also find their phenotype as well, like here CD8 positive. So this is the clone that I detected from the literature. So as you see here, the variable, they share the same variable and joining gene and a similar sequence of CDR3. And there is one motif here, DRG motif, which from the literature, it says it's a conserved motif. And the main difference is this 2 amino acids between my top clone and this clone. And also, as I said, my clone 5, which is also a high frequency, relative high frequency clone, share a similar sequence with my clone 1, except one amino acid. But more interestingly, actually, when you look at this epitope in the vaccine sequence of BioNTech that this patient actually received, you can find this epitope in the sequence. Of course, this is not a certain proof that these clones can go and bind these epitopes, or these epitopes are presented by the MHC1 molecules on the hepatocytes of these patients, but at least they support the idea that there might be some SARS-CoV-2 spike-like TCR sequences on the tissue which can expand. And of course, now we just showed that there are some T-cell sequences, but it is at the end a bioinformatic analysis based on the next generation sequencing, and we wanted to further validate this data in situ on the level of tissue. And for this purpose, we used an assay called Bayescope RNA in situ hybridization assay. Actually, it's a derivative of another assay called, a famous assay actually, is called RNAscope, which help you to identify, to actually detect RNA sequences on the tissue visually. So I just want to explain how it works. So you have these probes. In our case, we designed a custom probe specific to my T-cell receptor sequence. And this probe can recognize the target sequence. And by using some preamplifiers and amplifiers, you can amplify the signals coming from the enzymes or the fluorophores, which brings you the sensitivity of the assay. And to have a specificity, what the company says actually is that if these probes don't bind the target sequence, you cannot get any signal. So this brings the specificity. And this assay actually successfully performed in a couple of papers. It's not so quite common and well known, this Bayescope assay, but nonetheless, it's already used in some papers. For example, in this case report of fatal checkpoint inhibitor-induced encephalitis, the researchers detected a high frequency clones, as I did, and this clone frequency was like 20% in their study. And they use again TCR sequencing for this analysis. And then they managed to detect these clones on the tissue. So what you should see with this assay is this dotty red dots or pinkish dots. So here I think you're able to see these dotty cells here. And also what you can do to further characterize those cells, you can combine in situ hybridization with immunohistochemistry, and you can actually phenotype those cells. For example, here, they stained with CD8 positive, CD8 antibody, plus RNA in situ hybridization, and they showed that actually those sequences are not on the CD8 positive cells. Instead, those sequences are CD4 positive T cells. Here they show a combination of the CD4 and TCR, this in situ hybridization experiment. So this assay looked really helpful, and then we wanted to use this assay on our sample as well. And first, we validated that the assay actually works in our hands. So for this purpose, we use a positive control probe, which was provided by the company, and a negative control probe on a HeLa cell pellet, which expresses this positive control RNA, and as expected, it does not express this negative control RNA, which is a RNA from a bacteria. And as you can see here, these HeLa cells can express these dots positive cells all around. And in a negative control, you don't see this dotty red dotty signal. And on top, of course, we performed the same experiment on our liver explant tissue that I showed the results. And unfortunately, I could not perform this experiment on the biopsy tissue because I used all the biopsy material just for the sequencing, and the tissue size was extremely small. So now I don't have any remaining liver biopsy. And so I performed this dual RNA in situ hybridization plus immunohistochemistry assay. And so this red dot that you see is the positive control probe. And this means that this assay works on my tissue and my RNA quality on tissue enough to obtain the signal from this probe. And plus, in immunohistochemistry, you can see this dark stained circles around those cells. This means that those are CD8 positive T cells. As a note, my antibody did also some background on hepatocytes. So those cells that you see are actually hepatocytes. You can also see from the size that they are around 20 micron. But mainly this region is the immune infiltrated region that we observe the CD8 positive T cell infiltration. And also observed that there is no signal, red signal in the negative control probe. And one important thing is that I always use consecutive tissue sections. So what you see is exactly the same area. So you can also track it from, for example, these hepatocytes from here. This is exactly the same region. I found exactly the same region. Those are different tissue sections, but the region is the same. And of course, I performed my target probe, which targets my dominant clone, high frequency clone. Plus, I combined again with CD8 staining. And what I observed, again, exactly the same spot that I used, that I showed you in a negative control probe and a positive control. I observed those cells with this red dot positivity. So here, there are multiple cells with dot positivity. Even some cells have more than one dots, like 3-4 dots. And this actually validates the finding that I obtained from the TCR sequencing results. And on top, those red dots actually coincided with the CD8 staining. This means that actually the clone that I detected is CD8 positive cell that as I said, I expected this finding. And one final data I would like to show you, we did it very recently. So the main drawback, main challenge of this assay is that you have to get different tissue sections each time to stain your samples with different antibody and target probe combination. Let's say if I want to use another antibody, I have to cut another section and I have to perform again this RNA situ hybridization with another antibody. I cannot combine different antibodies. I cannot multiplex it on a single tissue section. And also, I have to use up my tissue sections, and they are very valuable. After a certain point, if I use everything, I cannot do further analysis. So to actually avoid these obstacles, I wanted to combine multiplex immunohistochemistry staining with RNA in situ hybridization. So as far as I know, in the literature, it's never been tried before. So also in this aspect, I think methodology-wise, it might be original. So what I did actually, I performed a multiplex immunofluorescence staining with this phenocycler system that I presented before. So this is my liver explant tissue that I mentioned here. So arginase positive cells are hepatocytes and CK19 positive cells are cholangiocytes inside these regions between hepatocytes. And so first I obtain a multiplex immunofluorescence staining. And then I clean up the tissue and I use the very same tissue to perform the RNA in situ hybridization. So basically, and I obtain the data, and basically what you see here is that the same tissue section, and you can easily overlay these two samples because it's exactly the same tissue section. So first, what we observe is a really high CD3 positive T cell infiltration, plus a mainly CD8 dominant T cell infiltration in the immune-rich areas. Also, I saw granzyme B CD38 positivity as well in my tissues, and relatively less CD4 positive T cells. And also, I did not show it here, but there were really sparse CD20 positive cells. And it also shows that this sample is very CD8 positive T cell dominant disease. And then I would like to show you a region because I, for example, detected my red dot positive cells. Here you can see some cells here. I hope you can differentiate this red dot positivity on the cells. So as you can see here, this region is exactly the same region here. So for example, this cell and this cell is this dot positive cells here. And you can see here, these are CD8 positive T cells, as I showed before in the other assay. And I also validated that they are not CD4 positive cells, plus they had this granzyme B expression. So this means that actually those are CD8 positive, and plus though they show effector function, and also they were CD38 positive. So we might be actually looking now the cells that Freiburg group actually observed before, because they also saw the CD38 and granzyme B positive in their spike-specific T cell clones. So with this final data, I would like to conclude my presentation. What we observed is the metabolic pathway enrichment in the vaccine-induced liver injury cases, and more CD8 dominant T cell response, and plus a oligoclonal immune cell repertoire in the T cell compartment, also in the B cell, but I did not show the data. And in line with this data, we observed a very high frequency dominant clone in the severest case in the literature, which showed some effector phenotype. So I'm at the end of my presentation. I would like to thank all the collaborators that helped us during our studies. Especially, I would like to, of course, thank our group leader, Matthias Matter, from the Department of Pathology in University Hospital Basel. He involved in every part of the design and plan, and also interpretation of data and writing manuscript. He's a super helpful group leader. And also my colleagues, they helped a lot, especially Carl Zinner for the analysis and Asmita Pant for the experiments, plus the analysis helps a lot for the data, and also a pathology department, of course, microscopy facility helped us to perform this analysis, this image-based analysis. And as you can see here is also from different regions of Switzerland, and also different countries, people helped us a lot. Benedetta from Epatacentro, Ticino, she involved in both the first and the second part of the study, and Jiang Lab from US, and also from Freiburg, Bench Lab, they helped us especially for the revisions of the paper, and Dr. Jumal Efe from Turkey, he provided us the samples in the second part of the presentation and help for the clinical data as well. And I would like to thank you all for your listening. Thank you very much.
Okay. Yeah, can you put it in?
Yeah, I can stop sharing, I think.
Stop sharing, yeah. So we can see each other. Okay. So thank you, Sarp. This was a very nice presentation. I like the way you presented with your data or the manuscript in preparation, and compare it with the other publications, which was really clear. One of the things that I want to ask you, for these cases, did you keep did you isolate the extracellular vesicles to see the content, just to understand a little bit the whole mechanism, no? Because the the immunofluorescence stainings were amazing. No, I really like this arginase and CD4, CD8. This was super clear, and I think we are unable still to do it in our lab, but I think we should do it in the future. But I think one of the things that is missing, or at least in my mind, is the mechanism, no? And maybe the extracellular vesicles and the content can explain it a little bit. What do you think about this?
Yeah, I mean, we did not focus on extracellular vesicles, to be honest. So it's of course still missing the, like, say, the final link or the final explanation, I think. So we
Yeah.
are observing something that might explain, but still I can only say might explain because it's not a certain proof. You're absolutely right. In the study, we did not focus on this part too much. And also, I think what we need, I don't know if it's possible, maybe the fresh samples. So to collect the fresh samples is an obstacle. Also, these patients are quite rare. This is why the Freiburg group actually performed a really nice study by having those fresh samples and using all this flow cytometry and deep spatial analysis. So I think this might be the missing thing that we have. So FFPE samples are really limiting factor for us, unfortunately, although it helped a lot for the spatial part of the analysis. But yeah, as a summary, we did not focus too much on the extracellular part, and still it's not at the final point, and it's not certain that those explain everything, actually.
Yeah, thanks. I mean, I think you will get there. I mean, it's just you're just missing a little the final point, but I mean, it's really, really nice the study that you did. Do we have any questions? Joanna.
Actually, yes. Sorry, I
You raised
was
your hand.
trying.
Yeah, I saw it.
Yes, I was trying to find the icons. So thank you so much for your presentation. Impressive work. Congratulations.
Thank you very much.
I have a small technical question, because I mean, this data that you get is really impressive and really important, and mostly, and of course, quite dependent on the samples and the biopsy samples that you can get. This is something which is crucial, because it's very hard to get this type of samples and to have them in good quality and in sufficient amount. So my question is, do you have a minimum amount of biopsy samples that you would need for this kind of assays? Because sometimes we have really, really low amounts of samples that we have from the biopsies, needle biopsies, for instance. Would that be enough for this kind of assays?
Yeah, of course, this is a very, I think, crucial question, because the main limiting factor for us is the material. So as you see, I always try to save some samples for further analysis, because each cut actually also cuts a piece from my heart, actually, I would say, because I lose the samples and I cannot do anything else with the sample, and I lose the patient, all those information, and we don't have the fresh sample. So and
sometimes we have to make options, like to what kind of assay will I do with this? Yes,
exactly. And for example, for the spatial, for the immune fluorescent part, actually 5 micron section is enough, and a small piece of biopsy can easily be enough for immunofluorescent staining. And but for the TCR sequencing, for example, you need a certain amount of RNA. And so it depends, of course. For example, for my studies, I use 15 to 20 micrometer sections. So this means that 3 to 4 cuts from liver biopsy samples. So generally, I can say 10 to 15 cuts, 10 to 15, 5 micrometer cuts from the samples. 10 to 15 different sections. So I can still spare some for the further analysis as well. So actually, I use the same RNA for whole transcriptome. And for the whole transcriptome, I did not use high levels of RNAs, concentration-wise. For the TCR sequencing, I used 20 to 30 nanograms, measured with a fluorophore-based assay, not with the nanodrop, for example. So in this case, I would say a small piece of liver biopsy, if you can get 5-10 sections, it is enough to perform all those analyses, actually.
Okay. 5-10 sections is not, it's a lot. It might be a lot, but okay, but yes.
Exactly. It might be a lot.
That's what it
depending
is.
on the
It's what it
sample.
is.
Exactly. And one possible solution might be that you can maybe, if you use the FFP samples, paraffin samples, you can melt this and spare, for example, one piece of the liver biopsy, because sometimes in our institute, we receive 2 pieces of liver biopsy. You can spare one piece and you can cut the other piece, and maybe you can use the other piece for further analysis. This might be an option.
Thank you so much. Sorry. So we have here a question from Nelia.
Yes,
No?
yes, from Nelia. Yes, you want to read it, Joanna, or I can read
Maybe
it.
Nelia could do it herself if she would like.
Nelia, you want to? You just need to turn on the microphone.
Yeah, of course, I can try. I don't feel so confident with my oral English, but I could try. First of all, I would like to
No problem.
Really, congratulations. Your conference was incredible. I am 100% clinician, and I understood you, and I could follow you, and your results are really, really excited. So I would like to know if, do you think that this kind of studies could be practiced in another daily patient, another daily cases versus autoimmune hepatitis? You know, maybe a drug or a herb or something like that.
Yeah, actually, in our paper, maybe it was a missing point, and also it was a reviewer question as well, that if we can compare with some autoimmune like drug-induced liver injury cases as well, for example, because we only compare with autoimmune hepatitis and the vaccine-induced liver injury, but it shows also some DILI-like features as well. Actually, we performed the immune staining by adding 4 autoimmune like DILI patients as well. And also we saw some similar CD8 to CD4 positive T cell ratios. It was also in the publication. I mean, if you're interested, you can, of course, go and find this data as well. But we did not perform further analysis with TCR sequencing or whole transcriptome analysis. That might be really interesting, because in the whole transcriptome analysis, by using just bulk RNA, we managed to actually separate some different cohorts. And also we had some, for example, ICI hepatitis cohorts that we added, integrated in this data set. And we also managed to somehow separate this cohort as well. So might be very interesting to see DILI cases, if they can cluster separately or different pathways got activated, or if I observe the same metabolic or mitochondria related pathways in the DILI cases as well. I think this might be quite interesting, and I don't know if there are studies focusing on morphological or molecular perspectives by using these liver biopsies on DILI cases. This I don't know, actually.
Okay, thank you very much.
Maribel, go ahead.
Thank you all for the invitation.
Hello, Uzun. Congratulations. Really excellent presentation, and also very clear, as Nelia has commented, very easy to follow. I think I am not aware of any other morphological study as the one that you have presented in other DILI cohorts. And I think it will be very important, drug-induced autoimmune-like hepatitis. The problem is the scarcity of samples. That's the main problem, no? But I think that now you have a treasure, because there are no more cases of, at least at our hospital, we have not seen any more cases of vaccine-related acute hepatitis. So really, but anyhow, I think we will appreciate if you could share the procedure that you follow to, once you get the liver biopsy, how to take the biopsy and how to proceed with before getting it frozen. And I was going to ask you if among the cases, among the cases that you have presented, you have first episode and second episode. And you could see clearly that the second vaccine episode, there was higher increases in transaminases in all those cases. If you could find, because you have shown first vaccine episode, second vaccine episode, and then a fatal case with regards to the liver, no? Of vaccine episode. And I think it's very nice what you have presented, the high frequency clones. If there might be any difference between this type of vaccine-induced acute hepatitis presentation in the results that you have found. I mean, it's just to try to identify something that could forecast what is going to be the evolution in some way, because you said that there are remaining T cells that remain, clones that remain during the whole process, no?
So, yeah, I mean, my idea is that actually in the severe case, it's a unique case. Still, I don't know why this happened to this actually case. What is the real reason? Might be MHC pathway alterations that was shown before, for example. But in the other case, all patients went to remission. So my idea is that actually there are some maybe T cell clones which can recognize certain antigens, but in most of the patients, those clones by using immunosuppression with the steroids or maybe with time without even any treatment, they washed away from the liver and somehow does not cause the disease. And of course, it's maybe important to check the relapsing cases if we can detect the same clones before or after. But in this most severe case, I think the main pathological reason is that this clone stays there and it's high frequency and you cannot wash it away. So it causes the damage, hepatocyte all the time. And you cannot suppress with the immunosuppressives. You cannot do anything with the plasma exchange. So basically it stays there. But the other cases, they went to remission. So I think the mechanism might be similar, but in the other cases, those clones, I think they washed away or they somehow suppressed, although they stay there. But in this unique case, I think it kept damaging the tissue. So this is the main difference. So this is why I think it's really hard to foresee if someone will get the disease or if we can see the evolution. Maybe in a really severe case, we can check the clones, if those clones change or not, we can do this. But this case was really unique and this is the only case that I know. So I think by using this TCR sequencing, it's hard to forecast the future.
Yeah. And I think you should also go on to the immune checkpoint inhibitors, drug-induced autoimmune-related liver injury, no? So I think that's something also that will share some light on the mechanisms.
This is also very interesting because it is, I cannot say it's similar because we saw some differences, but again, you boost the immune cells there with immune checkpoint inhibitors by using immune checkpoint inhibitors. So there might be some shared mechanisms related with the T cells. We had some actually observations. So might be the mechanism different, but still these pathogenic T cells, I suppose, they cause the disease. They cause this hepatocytic type of damage also in the immune checkpoint hepatitis cases. That's for sure true.
Okay, so all the best for the future.
Yes, thank you very much, Sarp. It was a great presentation today.
Thank you very much for inviting me. It was a great pleasure.
Okay, Joanna, anything to add?
No, I don't have anything else to add. Just to thank again Sarp all the participants in this meeting, because this is not only the speaker, also the attendees that make this so fruitful and the discussion so fruitful. And if no one has any other further questions, I think we could close it.
Yes. Okay. Thanks a
Yes.
lot, everyone.
Thank you so
Okay.
much.
Good night. Good afternoon, everybody.
Bye-bye.
Bye.
Bye-bye.
A good day. Good morning, Nelia. Bye.
Yes.